What is this, episode 5? We're pretty much veterans now.
Yeah, I think so.
Oh. All right. Well, welcome to episode 5 of ARME Radio podcast, the show where our goal is to tie in research with the practical setting and where we want to try to educate anybody within the health and fitness profession. So today we've got a very special guest. Is that a good way to put it? Mike, I'll let you introduce Jim here.
Yeah, so Jim's a good friend of mine. We've been talking online for a long time, both professionally and as friends. But Jim has a unique background of being both a chiropractor and a medical doctor. He originally did his chiropractic degree at Logan and went on to do his medical degree and is now doing his residency through the University of Pittsburgh. He also takes on a lot of roles related to intercollaboration and staying up to date on the research. So I won't get into too many nitty-gritty details because Jim will probably elaborate as we go on.
Thanks, Mike. Thanks, everyone. Glad to be here.
Alrighty. So today we're just going to kind of like have a little story time with Jim, just kind of go through stuff that we want to do. Not really anything major. No real topics that we want concrete, but let's just start off with the basics, I guess. Like, what exactly made you decide chiropractic to start and then medical school after that? Because that takes a certain kind of individual.
Yeah, you've got to have some kind of endurance, that's for sure. So I have always been interested in musculoskeletal medicine, and growing up, I was an athlete. I played sports my entire life. My family knew several chiropractors, two in particular that I would go to when I was injured with the sports I was playing at that time. And they were very focused on delivering the care needed and not more than that. They wanted me to get back to functioning well. There was a heavy emphasis on exercise-based approaches. Of course, manipulation was part of that. And so my experience with chiropractic, which was positive, influenced my thinking in terms of career opportunities when I began thinking more intensely about healthcare. I had not, at that point in my life, really through undergrad, had contact with physical therapists. So I just did not know much about that field. It's not like I knew enough to decide between one or the other at that point. And so I went to chiropractic school. I was frustrated at times, to put it mildly, by certain factions within the profession. It's a very, as we would know, it can be a bipolar profession where we have some people on one end who are practicing retrograde medicine that really is taking us, or healthcare that's taking us backwards and not looking forwards. And then we have others who are at the forefront of spine care and doing wonderful things, engaged in high-level research and moving the needle, to use that terminology. And I think that that's a positive thing for the profession. I graduated from Logan, and then I moved to Charlotte, North Carolina, where I'd gone to high school. I was set up to start an associateship with one of those two chiropractors I mentioned who had a positive influence on me. And I like to say, to his credit, that he made the mistake of introducing me to Craig Brigham. Craig Brigham was an orthopedic spine surgeon at Ortho Carolina in Charlotte, who the first time I attended one of the weekly spine conferences there on a Thursday morning, mostly as an early attempt to network with the community, he happened to be lecturing. So Craig Brigham was lecturing, and all of a sudden he starts talking about the biopsychosocial model of care. And I'm like, what? This goes against everything I was told, right, about orthopedic surgeons. And here's this guy who's not only talking about it, but at an extremely high level, knowing more facts than anyone I'd come across up to that point, really. So after he finished his lecture, I went up to him. I said, hey, do you mind if I come shadow you sometime? And he gave me this surprised look, and he said, of course, he couldn't believe that this chiropractor wanted to come spend time with him. So I did that, and it was really just the beginning moment of what would become a very productive professional relationship and mentorship, actually. So I ended up spending a lot of time with him, and to the point where he says, you're not a surgeon. I want you to have my knowledge, but that's so that you can know when it's appropriate to start thinking about when someone needs surgery versus all the majority of cases that can be managed, non-operatively. And one of his close friends was Jim Rainville. And Jim Rainville was the chair of the spine physiatry department at New England Baptist Hospital in Boston. And so Brigham says to me, you need to go spend some time with Jim Rainville. And so in the summer of 2011, I end up going up there, spending a week with him, with Dr. Rainville. And it blew my mind. This was this incredible educator who had an extreme command over the literature. He was great with patients, and he was organizing, really since the 90s, a rehab exercise-based approach to chronic low back pain that was kind of spearheaded by a PT named Lisa Childs, who had formal training in cognitive behavioral therapy. And there was this wonderful, truly interdisciplinary program that they were collaborating on and having tremendous success with. And so in the 90s, he had created this back boot camp there in Boston. And I said to myself, that's what I want to be doing. So I actually ended up spending 2 more summers going up to Boston to see Dr. Rainville. And in fact, he is going to be speaking tomorrow morning to my residency. So he's still very involved in, my development. His outgoing fellow from this year is a good friend of mine. We stay in touch, and we're very like-minded in how we think about spine problems. But that's kind of the course in terms of the evolution of my thinking and how I saw myself moving in the direction that I am now. And I would say that one of the key factors here that has to be appreciated is I did start developing an interest in research, and I also had an interest in leadership. And so there was a point where I had to ask myself, what could I do to position myself in a way to have maximum influence over people in spine care? And this is not the decision, of course, for everyone, and certainly unlikely to be the decision that's best for most. But I decided I needed to go back to medical school and kind of acquire a certain amount of cultural authority so that I could, get inside, so to speak, and understand the thought process and the language of folks who were very influential within spine care. And so that's why I decided to go back to medical school.
That's really noble, that giving up an extra 8 years of your life plus giving up the career that you already had to better serve patients and help people more than you were able to with the skills that you had. That's uncommon. And if we had more people with that mindset to always keep improving the best they can, we'd probably be getting a lot better outcomes.
Yeah, I mean, just to follow up on that, so you have to have the family and social support to do it, right? Like, that's certainly a limiting factor for some people who otherwise have an interest in doing it.
Yeah, absolutely.
And, so my wife is in healthcare. She was a critical care nurse for 7 years. She's now a nurse practitioner in neurosurgery here at Pitt. And so she understood the culture of healthcare in a way that mattered for what I was wanting to do. And she was supportive the entire way, which was crucial to being able to do it.
Jim, you said that you went back to, you thought you had to go back to med school to get the cultural authority. Do you think that maybe now times have maybe changed a little bit, or is it possible for people not within that profession not to go get their MD and still have some type of authority to make those bigger public health changes?
Yes, I do. I certainly do. And I think some people are great examples of doing that. One of my mentors, Mike Schneider, did that, however, by getting a PhD, which opened specific doors to him that have allowed him to thrive. So he did not do the medical school route, but he did do something else, right?
Yeah.
Jim, are you okay speaking to Schneider's role right now at Pittsburgh?
So he's a research professor in the School of Health and Rehabilitation Sciences, doing highly funded NIH work on low back pain. He has been instrumental in some research that I'm doing right now in the prehabilitation space, specifically for patients undergoing surgery for lumbar spinal stenosis, and is respected by orthopedics and PM&R, as well as the physical therapy community, and of course chiropractic. So he's a great research model to look to. There are a lot of those. And I think, just to step back for a quick second, the reason that you consider going back for that cultural authority that I mentioned, you don't have to have it, but you probably are going to spend less time trying to force doors open that open more easily when you do, right? And that was some of my thought process, is I wanted to have an easier time to kind of get to the point, so to speak, right? To be able to get into a position relatively rapidly. I know that's funny saying it from someone who went back to medical school, but I've been a beneficiary of someone who has been able to operate at a relatively high level, within academic medicine pretty quickly, along my career, even as a resident now. So I'm very happy with what I've done and the positions I've been able to get myself into to have a voice. And that's what this is about, right? This is about giving patients the right care, but this is also about having a voice when you think you have something significant to contribute to this discussion of spine care, which, as all of us would know, is a black eye in medicine, in healthcare. Like, we have not done a great job with it. And so we need to change our thinking, we need to change our approaches, and we need to do a better job. And that was what was kind of a motivator for me. I wanted to get myself into a position where I could do that more.
You did touch on, you mentioned prehab or prehabilitation. That is a buzzword that goes around the fitness industry a lot, saying, oh, we're going to do some prehab here. Before you squat or anything, we're going to do some stretches. And that's your prehab. Obviously, this is quite a different type of prehab. Can you touch on what you do with these patients with spinal stenosis?
Yes. So the prehabilitation concept is really one of working with relatively high-risk populations. So in our case, we're looking at patients who are already screened and planning to have lumbar fusions, okay, for refractory lumbar spinal stenosis that is sufficiently bad that it's interfering with their quality of life. They've been through the system. They kind of reached that end of things. And the idea is there are certain outcomes that we care about improving on in those populations, because this is tends to be an older population, right? They tend to have functional limitations. Their ADLs are disrupted. They might even things like their transportation access. All of that creates complication for having a good outcome, potentially, in some cases. So we're trying to take that information and feed it into the continuum of care earlier, so that they get better information sooner, so that they know what to expect. So we're trying to manage expectations. We're working with physical therapy to make sure that whatever their functional limitations are, we're addressing those much sooner than post-op. So that's really what we're talking about here. Where we see this working really well is in transplant surgery, certain types of abdominal surgery. We're seeing this work well in hip arthroplasty as well as knee arthroplasty. So actually here in Pittsburgh, for total hip and knee, it's already included as part of their required surgery package, so to speak, because it's so successful in terms of improving certain outcomes. So one of the next logical steps, we think, is spine care. And so that's kind of what we're doing right now, is looking at that for spine care.
So those patients who are undergoing knee and hip replacements, they are required as part of their pre-op to go through this this exercise program and preparation before even going under the knife.
That's right. So I would tell you that our pilot work right now is very lean. So we're just trying to start to see what kinds of effects we can have. It's heavy on patient education. There is some physical training to it, but it's not a conditioning program. So it's a little different in that sense. We're not working with them for several weeks on end to try to build up their physiologic reserve in this case. That is a strategy, and that's really important for certain surgeries, for example, transplant surgeries, right? Where you do need that physiologic reserve built up. Like, you have to have a pretty intense approach so that they can literally, survive the surgery. And this is a little different. So we're looking at a pretty lean program. There's an in-person clinical component, and then there is telemedicine as well, to reinforce the principles that we're trying to get across to them. Yeah.
So Jim, I wanted to ask you quickly, in regards to the collaboration, you have orthopedic surgeons, you said, physical therapists, there's the physiatrists. Are there any other major roles that you can think of right now in that group that you have?
So really we have a certain orthopedic spine group that's working with us. And then we have a certain physical therapy location, who, by the way, we have people who are dedicated to training them for this. So there's additional training for the therapist as well. I can tell you that the therapists that we're working with already have the primary spine practitioner certification, but we're still on top of that, training them for the purposes of our needs. And the thing that is important is, yes, physiatry is involved, and then nursing, who works closely with the orthopedists, are involved.
So you talked about doing that additional training with some of the people that you're working with. With your experience having gone through 2 different professional schools, the only thing you're missing is like physio, I guess, to get the complete answer. But where do you think educational institutions of any kind dealing with MSK conditions could improve their education? What do you think's missing from MSK education?
That's a great question. For one thing, we often get frustrated because we say that there are all these guidelines out there about how we should be practicing we're talking more about spine care in this case. And yet that doesn't happen very often, right? Like there's a huge disconnect. But the issue is more economic, right? Like we really have to start talking about that part of this more. That requires us to acknowledge that humans are more or less the same. Our training can be very different, but the way that we process and do clinical care is relatively similar in ways that count. And so we definitely can't finger point. This is not a surgery person problem. This is not a non-surgery person problem. This is not a therapist problem. It's not a chiropractor problem per se. This is a community problem that is heavily, and we do not emphasize this enough, heavily driven by the economics of the system.
Can you say a little bit louder for the people in the back?
So that's why, I have a really easy time working in interdisciplinary environments and collaborating with people. And the reason is that I really try to embrace this logic and own it, which is that we are all way more similar than not. And human behavior is a lot more predictable than we acknowledge. We're not very different. You have to change the environment. You have to change the conditions in which we work. You have to change the incentives so that we can drive behavior in different ways. And so I don't think this is a problem that we can fix by giving more biopsychosocial lectures per se. Yeah, I think that's important. You have to hear it. But I ended up hearing a whole lot of stuff in medical school that people are like, oh, they aren't taught this. Well, no, you do hear it. You are exposed to a lot more than one would realize. It's just you have to then align practice with the incentives to make sure that that is the way you focus your time, right? Because it's all about time in the clinic. It ends up boiling down to that. A few people are able to do sort of extracurricular sources of income so that they can free up the way that they spend their clinical time. But for the majority of people, their clinical time is really bound in a confined way by how their incentive structure is put into place. And that's what we have to start thinking more about. And I do think it can change, but we've got to have more voices who are caring about leadership and advocacy and working directly with those who are delivering the payments for what we do clinically. So that is an area that, I'm interested in. And part of this whole prehab concept is, again, premised on improving outcomes and ultimately saving money for the system.
That's a really good point. I think the economic side is often forgotten. We were having a pretty good discussion on the evidence-based chiro page with Michael Ray. He came in, and we had the one point that was brought up is that one of the inherent risks of some of these manual therapies that we often say don't come with very high risks is people overpaying or overuse of them, right? So that it seems like it's forgotten.
Well, Dave, what did you mention? Or what was mentioned about Equipost? Maybe those adjustments might help. Well, let's go to the performance argument. They might help your performance like 1%. If we want to throw an arbitrary number on it. But if you're paying $70 a treatment session and you can get the same benefit from just exercising at home, why? Like, you've got to ask these big questions, like, why are we doing one thing over the other if this has been shown to be just as useful with a minimal price associated to it?
Yeah. So, and along with that sort of economic question is what I was touching on with you have to change the environmental conditions in which we work, right? Like in terms of our clinic practices. So that's a discussion that I think we need to have a lot more.
So I have a question that kind of builds off that for you, Jim. So I think last year, Ben Darlow came out with that free study that looked at GPs coming in and how they were handling incidents of acute low back pain. Mm-hmm. And they had educated a group of GPs about the course of natural low back pain and how to incur and basically like worked with guidelines. So reassurance to keep active, education on the course of low back pain. and just encourage people to keep going and keep active, and then compare that with the group that didn't receive that training. And it was a pretty significant difference, right? At 6 months, both groups were doing the same pain-wise, but one group had spent on average almost $900 more than the other group. So I guess my question for you then is, how do you see that shifting in the landscape of just general medicine? Like, do we see that there's more education on what guideline treatment is, and why, if there is there a barrier in medicine to following through guidelines for low back pain like that?
Yeah, so I'd be interested in the long-term outcomes there, right? Like was it sustainable? Did those practice behaviors change for the long term? Research studies are very good about putting sort of structure in place. And we might see certain outcomes occurring during the course of a study that are favorable because of the nature of the study itself. In general, I think that it's pretty much the point now where general practitioners hear all of this information. Okay. In medical school, you know, even though I'm out for a few years now, like we were already coming across this, you know, we're coming across the fact that a lot of the findings on diagnostic imaging are not reflective of the clinical problem, that there are a lot of asymptomatic findings, and that, you know, we need to be aware of that huge gap that can be present. And so the question to me is, how do you offload an already overburdened clinician like a GP or PCP? Okay. Because the reality is, I don't have any more respect for anyone in medicine than a primary care physician or clinician. Okay. Because here's the reality. People sometimes get frustrated by this notion of subspecialization and this hyper specialization that is happening now in healthcare. But the reality is that our knowledge base, because of the growth of science, is so big, it's so broad, that no one can any longer know everything. It's just not humanly possible. There's too much to know. There's a reason that we have people who spend extra time focusing, you know, just on the kidneys or just on the cervical spine in the case now of orthopedic spine surgery, right?
So Jim, quick question. Do they actually have specialists for like orthopedic surgeons who just specialize on like T7 at this point? Or are we not at that point yet?
We're not at that point yet. Well, we are at the point where in big cities, you will see orthopedic spine surgeons who just do cervical spine work.
All right, that's okay.
You know, so the reality is that there's a whole lot to know, and it's a pragmatic decision to focus more specialization in the way that we are right now. It's out of necessity, and I think that it's really important for us to acknowledge that if we can offload general practitioners when it comes to musculoskeletal, and especially at least spine, that's probably a good way to go. And that's a good avenue to explore. And I'm in favor of that. And I think that's one of the things we're trying to do here now in Pittsburgh in the ED. A few places have tried this and are doing it. And one of the concepts is for those patients who have an acute radicular pain problem or an acute back pain issue, they should probably be seen by someone who can help differentiate the actual seriousness of that, so that you're not asking an ED physician who is responsible for all of these undifferentiated patients, right? They're the true gatekeepers of undifferentiated care. And if we can help them out, then that would be a good thing. So I'm in favor of plans that are looking to do that.
This might be a really broad question and put you on the spot, and I don't mean to, but what can chiros and physios do to make life a little bit easier on our general practitioners, to ease their load? Because there's such a big difference where if a medical practitioner refers to one type of person, they might not get the same service as the other. It's a pretty complex environment. So what can we do to help?
Yes, so that's a great question. It's a tough question because I don't think there's one answer to it. I don't think there's one way to do it. I think that there are a couple of strategies. One is that you want more from a public health standpoint, the public to become aware of that as the first stop, right? Like if you have back pain, you should go to a certain provider or clinician first, and that's appropriate to do so. What's not appropriate is for your first stop to be a surgeon, right? That's what still happens too much. So that's a public health problem. The information in society about where people should go is bad information, right? And the reality is that surgeons want to see the right patient at the right time for the most part. They don't want to have to, send you back and say, no, you need to go to PT now, or you need to go to a non-operative physician first. They need to be saying that the people coming in to see them are appropriate for the kind of care they give. And that's increasingly what surgeons want and are asking. So part of this is messaging at a high level when it comes to the healthcare system and what folks who experience these problems expect or think they should be doing. And that's kind of a collective effort on all of us. I also think that in anticipation of a system where that is more likely to be the norm, chiros and PTs need to be prepared to do a really good job with it, because that is how you get buy-in, and that's how you make it sustainable. We don't want folks to have an ultrasound wand put on their low back spasm, every time they go in. We don't necessarily want even them to get, manipulation just because that's what you offer. Like, we want a very wide, sort of knowledgeable and skilled clinician who can deliver the right care at the right time and know what those differences are. And so developing a model for that within those fields is, I think, really important to take advantage of this movement, which there is increasingly a movement towards this, to get patients to go to the right level of care at the right time. That's where things are heading, okay? Surgeons are getting to the point where that's what they want as well. And I think we're going to see increasing shifts in that direction.
So, Jim, I want to just touch on that quickly. Do you think then, as chiropractors, we have the education, and you can be as honest or truthful as you want, to be primary care providers, in the sense where we can tell people and delegate them, yeah, we're not the right person to go to, but you should see this person, or you should see this person? Do you think as chiropractors we have that ability or that education as primary care providers right now to do that?
So I wouldn't use the term primary care provider, because I don't think that the training is there for that.
Yes, I wanted you to touch on that. That's kind of why I use those words.
Yeah, so as a primary, musculoskeletal provider, that would be a realistic thing to aim for, right? Or a role to fit in well. But the concept of being like a GP or a primary care provider requires enormous exposure at a high level of training, which is what residency and medical school is completely geared for, right? So basically, I tell people this: like, medical school is training someone to come out as a unfinished primary care physician, right? You do an intern year where you're just pounding it out across the board, seeing a huge spectrum of pathology, doing lots of different things, and getting schooled by lots of different people who are really smart at what they do, so that you can see with this very broad spectrum. And a lot of it just is about volume of intensely diverse pathology. You have to see it. You know, you have to literally get your hands dirty. You have to have patients that vomit and shit on you. Like it just is part of it, right? And
won't forget it.
You won't forget it.
Full experience.
Yeah, it's the full experience. So like as a general concept primary care person, that's what we're talking about here. You've got to be able to give vaccinations, right? You've got to know how to pick up the phone and speak intelligently to a vascular surgeon. You've got to know when you should and when you shouldn't, right? And those are really hard, complex questions that are just way more than focusing on musculoskeletal care. So it's really hard. It's intense, and medical school is super challenging. And you're in there with people who are as smart or smarter than you, right? And there's a reason for that, because that's the default product, is a general practitioner. Then you can do residency, where after your intern year of residency, you start to chisel down and narrow the field, right? And you do more and more that goes towards a certain direction. But even neurosurgery interns are doing more broad work. You know, they're working with the stroke team, right? In neurology. They're working with anesthesia. They're doing lots of different things. They're not just cutting brains. And
they're not just cutting brains. What?
So that's the thing, right? You've got to have the training circumstances to develop an opportunity. And so my personal thought is, that part, if you want to do that, you should go to med school, because there's not any place to do it better. It's just I'm
gonna say one thing. I really liked how you said that. That was really eloquent. Developing educational situations that give you opportunities. I think that's really what is lacking to some degree with our intern year, maybe as chiropractors. I don't know if anyone else wants to speak to that at all, but I think that might be a little bit of what we need to see, a bit more exposure of things in order to gain a bit more confidence with what we don't know.
Mm-hmm.
Yeah. Well, when you compare the number of hours spent in the classroom learning about certain subjects between the doctor of chiropractic and medical doctor, the amount of time is similar, but it's the exposure. Like I would in no way be comfortable being in a general practice, and I'm happy to stay with what I know, which is musculoskeletal. And I'm sure that a lot of that you would agree with me as well. But yeah, it's practical application that you just don't lack. You should stick with what you're good at and be willing to realize that you're not God and send off to the people who are really good at what they do.
Yeah, we're not oscillating for bruises and stuff like that. We're, red flags pop up and we're sending it to someone who can. So Jim, you mentioned this a couple of times of knowing when to do what, knowing when it's the right time to pick up a phone and call someone or refer out, or what treatment might be more appropriate for someone, or when it's completely out of our hands. To me, that sounds like the definition of clinical experience, where we're often talking about how clinical experience is this massive pillar, or if we want to use the funnel. What is your thought on that? Because I think that that's a great way to put it, is knowing when to do the right thing at what time, not so much that I've had 30 years of practice doing this one thing and it seems to work. So what's your thought on clinical experience as the three-pillar system?
Sure. So, just to step back and say a couple of things. One is that, first of all, having said everything I said, chiropractic, physical therapy, they're in excellent positions to become experts in musculoskeletal care and neuro rehab. And you can focus on accessing experiences that facilitate high level knowledge and skill, right? So that's not to say that they need to become primary care. So I just want to clarify that you can still do wonderful things and get there.
Oh, Jim, we know we can do wonderful things. You're wonderful.
You're told on day one that you're going to do wonderful things at school, right? Like every day you walk in, you're gonna change lives. First thing, day one.
All like candy canes and puppy dogs, you know. But so the question about the clinical experience, yeah, that's crucial. So here's what I would say. You know, it's like there's this damn chart that goes around talking about, like, you know, chiropractic school versus medical school and stuff like that, and like it conveniently omits residency, right? Yeah. So medical school, let's say, you know, you spend however many hours they say. We can even go by their numbers, right? Like it's always a few hundred less than chiropractic, fine, whatever. But then in residency, you know, in about half the time, you're like doubling that amount of hours. It's just it's incredible. You know, it's a full-time commitment. There's a reason they literally called it residency. You used to literally live in the hospital and not leave. So the amount of hours that I've racked up just in 2 years, even as a PM&R resident, right, which is on the lifestyle end of the specialty spectrum. We're considered one of the lifestyle specialties now, supposedly, because it's a better lifestyle balance. You know, the number of hours last time I looked at it was, you know, it's well over 6,000 hours in 2 years of training, and, you know, something like 1,700 inpatient notes, not including any of the outpatient notes that we do. It's a lot of like encounters with patients, all kinds of patients, different experiences. And, you know, one person, when I was getting ready to go back to medical school, they said, you know, medical school and the residency process is about training pattern recognition. And it really is. You know, a lot of the learning approaches that we use in medicine is about repeatedly seeing the information and then, you know, sort of spacing it out so that you don't extinguish that information and you retain it long term. That's really what the training process is like. You know, you're seeing snippets of things continuously in different ways over time. And you start to build these internal gestalts about, you know, sick and not sick, mild and severe, you know, consultant, not consultant, questions.
Specific, non-specific.
Yeah, specific, non-specific, which is one of my favorite things to talk about, which I'm sure.
Great segue for later.
but yeah, so the pillar there is crucial. And you can never underestimate the fact that you have to see and encounter patients with these problems. You can't just read about them in a textbook, and you can't just read about them in an abstract either. You do have to see them up close and personally. And that's the training process that really matters. And yeah, I think every kind of healthcare professional benefits from that kind of immersion experience. And however you can get it, which some people brilliantly find ways to make up for deficits that they perceive in their education, including in medicine. And that's what we should encourage.
Well, if you even look at our podcast right now, you can kind of think of yourself as like the big shark, and we're all just the bottom feeder fish kind of following along anyway. So like this is our own form of like residency anyways.
Hey.
Sorry, just to expand on that thought, and I won't be able to come up with the name or the year of the study, like Ben might actually. But what are your thoughts? There was a study that came out that said the longer certain practitioners are in practice, the worse they get. Is that in fact true, or like what are your thoughts on that?
Yeah, no, I do think it is. I think that, and usually that has to do with people who are doing certain procedures over a long period of time where the variability stops. And that's crucial, because I think that's what the study suggested, is that when you stop introducing novelty and variability in practice, that can become stifling for progress or learning, right? And we're human. So naturally, as we get older or further along a path or consider ourselves to be more expert, we tend to become more rigid and less flexible with new information. So I think that's the difference. I think that it is an attitude, it's a mindset in terms of how much you are willing to engage novelty and variability in clinical care and seek it out. So to me, that's kind of what it insinuates, is that when you stop embracing those things, which is just a natural tendency for us, again, as humans, it's not a profession thing, it's a human thing. I think that's the trouble we can run into.
Does that maybe go back to the economic side of things, where this has been working and it's been putting money in my pocket, so I'll just keep doing it?
Yeah, I mean, if you get paid really handsomely to do one thing, 90% of the time, and you keep doing that thing for 10, 20, 25 years straight, that's not going to leave a whole lot of room for new opportunity. So I agree with that.
So I wanted to kind of ask you a question. I know you'd mentioned it before when we were talking privately, but about COVID and how you had to kind of take on the role looking at things more as a primary care doctor instead, not really looking at your specialist role at that point. Other physicians too, like you're in residency, so maybe it's a bit more fresh for you, but were other physicians also taking on that role with COVID, trying to help patients in the setting and diagnose? And was it a lot harder for maybe some of those, like I'll use the word veterans?
That's an interesting question. I don't know that I could speak to it in this context. And just to clarify, so I think in some places it was absolutely the case that we had to take on different roles. As physicians, you would see people de-differentiate, right? So you'd take a specialist and you'd have to ask them to do different type of clinical work because of the urgency of the situation. And that was actually part of the legal regulations that were relaxed during the pandemic. So for us in my program, what we did is in March, when we realized things were getting bad in the States, we stopped outpatient care and we moved towards all inpatient. Our inpatient rehab remained pretty full the entire time. So the way we did it is we had half of our program in the hospital on 2-week shifts, basically. And then the other half was working remotely as a support for the inpatient folks. So we would help with like chart reviews, we would help with admission preps, we would help with discharges, and we'd help with like calling consultants and families if needed to offload the inpatient team. The reason that we had the 2-week rotations is because you had to be quarantined for 2 weeks if you were exposed. We kept half the program outside of the hospital in case an inpatient team was exposed, then we could rotate them through. So that was a pretty dramatic change. And it worked out really well, actually, the way it was implemented here, just to make sure that everyone was rested and ready and capable.
Yeah. And I do have a question following up, kind of tying in COVID and our situation. So situation that a lot of us musculoskeletal providers are, we were put into is that we put in a position where some of us voluntarily closed our clinics to help reduce the spread and help promote social and physical distancing. And we turned to telehealth. some professionals, I know Craig Liebenson was really pushing the benefit of telehealth for
Mm-hmm.
musculoskeletal management. So one, with COVID, telehealth management for all kinds of issues has been more prevalent. And we're also seeing more and more telehealth for other forms. And you mentioned that you do telehealth as part of the prehab with the spinal stenosis patient. Could you touch on where you feel the benefit of telehealth and telerehabilitation is coming and going in the future?
Yeah, so first of all, I think telehealth was always going to happen, but COVID was a catalyst.
Mm-hmm.
Right? It accelerated our implementation. I think that was a good thing in terms of that specific part. I think we're going to see it continue as a more prominent part of how we deliver healthcare. A lot of large systems had to implement it rapidly, and they saw the ease and success of using it. So, here at Pitt, we've integrated it completely into our EHR, and every physician attending that I work with now every day has some amount of telehealth visit census that they use during their day. And there are certain types of things that are really conducive to using telehealth, including in surgery, especially for like post-op checks. And the interesting thing is that, and this is just a wild fact, I like to share it whenever I can, but so globally speaking, more folks have access now to smart devices like smartphones than toilets. That's pretty incredible, right? So this is a technology that is almost ubiquitous now. And so we have a new way to bridge gaps between the clinic and the patient. And I think that we're going to see it maintained as an integral part of how we not only deliver the kinds of healthcare visits that we were doing before, just remotely, but I think we're also going to see it used in new ways. So Brad DiCiano is one of our attendings here who is heavily involved in a rehabilitation-based mobile health platform. And it's completely geared to help collect important rehab-based information from patients when they're not in the clinic, so that they can communicate that with their clinician. I think we're going to see more of that. And I think it's ultimately going to be a positive that even once we get it down, will reinforce behavior change when it comes to health. So I think it'll be a good thing for us. And I'm excited about that and very interested in it.
Yeah, I think we all were in accordance when we started realizing how feasible it was, that this could be relatively easily implemented, and how it has been implemented already in some rural settings. And it just, like you said, it was just a catalyst to kind of move it forward. Yeah. What I am going to do now is I'm going to totally shift gears, and I'm going to get you to give me your best monologue on why I can be specific when I'm finding low back pain. So, or in the total opposite vein, you can tell me why we should continue to utilize non-specific low back pain. Now, I'm not going to tell you which one is right.
Okay, yeah, please don't do that.
Because I don't think we have at least 40 years of evidence. I think we're not there yet. We're one step away. So
also, don't be very specific with your answer, please.
Yeah, as specific as you can with your answer about, and talk just a little bit about your experiences, I guess, as both now a graduate of chiropractic and who had practiced chiropractor, and then now as someone in medicine, and then also someone involved with research. So all that for you, right on the table, right on the plate for you.
All right, thanks so much. So, there's this concept that goes around that we're being lazy, essentially, to use some words when it comes to the terminology non-specific low back pain. And I think that's the wrong way of thinking about it. I think when we say non-specific, we are being honest about the kind of diagnostic certainty we have, right? Which isn't to the level that we like, but it's a fact that we have to own. We don't like the fact that we don't know, in many cases, what is, causing as a specific or singular pain generator with back pain in particular. And while this is frustrating, we have to consider the fact that in order to make progress and to keep moving forward, we have to acknowledge the boundaries of our current understanding. And that's what we're doing by saying non-specific low back pain. Now, one thing that I like to clarify too is that we don't have to say to the patient in front of us, you have non-specific low back pain. And then they're like, well, what the hell does that mean? You don't know what is wrong with me? And, we don't have to do that. We can say, we understand you have back pain. It's really important though, that you understand this is a process that involves different factors, and it's fairly complex, right? Like the nervous system is complex, particularly in the case of chronic back pain. We know that there is an interplay between changes that have actually taken place inside your nervous system and your body. And we have to acknowledge that there's not a coin-sized spot that we can always go in with a needle and put lidocaine and make it all go away, right? And that's the reality. I don't think we're honest enough with patients about this. We continually chase the rabbit, and we continually send them down more expensive, more potentially hazardous roads. Now, sometimes there are specific problems, and we want to find those. So I'm not saying that we don't. And we need to be clear that there's a difference between finding a specific pathoanatomical issue and trying to address that with the tools that we have versus many cases where there is, pain that's in a region this big, right, for reasons that are more complicated than just a singular factor. So it's frustrating that our desire to understand more than we currently do sometimes forces patients down a road that's ultimately not good for them. And we really need to put their best interest in, at the forefront of all of this and take a step back and say, nonetheless, there are really good things we can do for you and with you, and that you can do for yourself, most importantly. So
I think that was about all we could have all hoped for to hear from that. And I think, again, just to kind of even add on, I think that, like you said, with the kind of the laziness misnomer there, I think a diagnosis of non-specific low back pain, and yeah, you don't have to give it to the patient, but that means you've done your due diligence. It's a diagnosis of exclusion, right? You've ruled out those serious pathoanatomical pathologies that you're worried about, that you should be concerned that are a possibility. And I know another point that we wanted to ask you about along that same lens was, so even if we are able to differentiate a left-sided multifidus strain or a right-sided facet sprain, do we have any data? Do we have anything that tells us that we would treat those any differently?
Right, so that's a great question too. And I think that, importantly, there's this acknowledgement we have to make where just because we use a given treatment and the patient improves doesn't mean that when we had an idea about what the diagnosis was, that it proved it. right? So sometimes people are going to get better, and we know that most people still do get better, that the natural history is favorable. And I think that overwhelmingly, when taken in full, the literature supports the idea that most people recover and get back to thriving in life with a favorable natural history, to their spine pain. We want to capture and try to help and spend more of our time on those who are at risk and those who might not get back to doing the things they want to do in life, right? That's where we should be spending most of our time. And when certain risk factors, which, can be a topic for maybe a next discussion that we all have together, because that's a big topic that would require some of our time. But once you identify risk factors, I think that it's your responsibility to take those patients along a clinical route that will empower them maximally, right? So they have the best chance of not losing their ability to continue their life the way they want to. And when those risk factors are not there, we need to embrace the positive natural history that patients are left with. And that is that humans are resilient, and we recover, and we have aches and pains, and we age, and sometimes we feel it, and some of us feel it more than others as it's happening in our bodies, and that's okay. It doesn't mean we're falling apart. And no one who is 45 years old has the spine of a 75-year-old, right? No, they have the spine of a 45-year-old with their genetics, right? Like, that's the reality. And we need to start being careful with how we frame things and how we talk about it, and ultimately how we work to empower people. Because what happens is, and Jim Rainville is great about talking about the narrative fallacy, this idea that when I become aware of something about me that's different from my peer, I want to explain it, right? And everyone with a back problem, quote unquote, wants a narrative for why it happened to them the way it did. And our job as good spine clinicians is to convince them that in most cases, that's too simple. And also, importantly, unnecessary for them to recover well. So that's kind of my general take on it.
When you drop your Yeti mic.
Yeah.
So we want, maybe take things a little differently, or change gears here. A lot of us aren't really too formally knowledgeable about like injections, PRP, nerve blocks. So I was wondering if you could maybe speak to your experience with that and your focus on that as a physiatrist, or maybe some of the pros, cons, some of the misnomers people have, and regulations surrounding it.
30 seconds for why PRP is good for everyone. That's all you have.
So I mean, in theory, it sounds great, right? So like, chiropractors are all about the body treating itself and, using what we have to make ourselves better, kind of thing. And that's essentially what PRP is. You're taking your own body, you're trying to kind of hyper concentrate what we think are really important growth factors for injury, and you're trying to then place it in the spot of an injury. And in theory, it sounds really good from the standpoint of, so you let's say you have an injury. So I ruptured my Achilles about almost a year ago now. But so you have the initial injury, and then your body does a great job at sort of initiating an inflammatory recovery cascade that is going to sort of send different types of immune factors into that injury to hopefully repair it to the best of its ability, which is not going to be the perfect tendon that it used to be, but it's going to come pretty damn close, and probably to the point where you can get back to functioning in many cases, hopefully most cases, really as well as you were before. Maybe if you're an Olympic athlete, that's going to be different. But that process, has an expiration date on it, and then it kind of stops and fizzles out. So the concept of PRP that I like in theory is you then take PRP, which is kind of hyper concentrated with the factors that were present early because of cytokines attracting them, and you put it back into the location of the injury and you try to reignite that process again, right? Like, so artificially re-stimulate it. There's a lot of research going on to understand if we can do that in the ways that we hope clinically. I'll kind of have to leave it at that.
So at this point, when you see in an advertisement that we're doing acupuncture on a tendon, or we're doing Graston or soft tissue therapy on a tendon to restart the inflammatory process, we just can't say that because we don't even know if that's what's happening or if we can do that.
I think a lot more research needs to happen. There are really good organizations that have the funding to research this properly that are doing so right now because of the interest. I do think in general, it can easily be oversold to patients beyond what we know. And that's where we have to really pull the reins back and say, we just have to be brutally honest with our patients about what we know right now. And that is that in theory, it sounds great. In the clinic, it doesn't always align with what we hope. And that's just the fact. That's just where we are right now. Some people get better, and we need to continue to understand if there's a different way to approach it that would improve on it. And I think that's most important. As an aside, separately from PRP, because they're not the same, I think we need a lot more reticence about stem cell therapy. And I think that's an unfortunate area where it's been far more oversold even than PRP in ways that are hazardous to patients. Unfortunately, I've seen patients with severe neurological disease that have traveled across country because somebody was promoting a procedure that cost ridiculous amounts of money and promised the world. And then we see these patients back months and years later, and there's no change. And so as clinicians, as colleagues, I think we need to hold each other responsible to things like what we currently know about the evidence, as well as the terminology we use, like non-specific low back pain. And we need to reinforce the good ideas, which are that ultimately all of this is really trying to get the patient the best information that we can about what's happening and what is likely to contribute to their recovery.
All right. Well, thanks a lot for coming on, Jim. Look forward to us chatting again in the future. And in the meantime, stay safe, and let's make this virus go away.
It sounds good.
Thank you so much, Jim.
Yeah.
All right, guys. Hey, truly appreciate it. It's an honor to be here.